Today we're going to talk about fluid and electrolytes and acid-base balance. However, we are not going to talk about renal disorders. Just a quick review. About 60% of the adult body is water. Of that 60%, approximately 40% of the body weight is inside the cells, and then the remaining 20% is extracellular, and then only 5% of that fluid is actually in the blood, in plasma. The rest of it is interstitial. Just a quick reminder that cations are positive, anions are negative. As far as the major body electrolytes go, you can see them there. Okay, just a very quick little review. In the body, fluid means water, and electrolytes are ions that are dissolved in water, such as sodium, potassium, bicarbonate, etc. Now, we also use, in the medical field, we use glucose. We include that with the electrolytes, even though it's not technically an electrolyte. Osmolarity and osmolality are measures of how much stuff is dissolved in the fluid. So how much it's kind of like a ratio of electrolytes to fluid. With the higher the number, the more electrolytes per the amount of fluid. And if you remember, osmolarity with an R is the number of osmoles divided by kilograms of solvent, in this case water. And osmolality is the same thing, except you divide by the liters of the solvent. In the case of water, kilograms and liters are the same thing, so they can be pretty much used interchangeably, and in clinical practice they are. Okay, when it comes to the major intracellular ions, you're looking at potassium and phosphate. And that makes a lot of sense if you think about it, because the sodium-potassium pump pumps sodium out and potassium in. At the same time, ATP, what's the P? Phosphate. So that phosphate is always being broken off the ATP and then being added back onto the ATP. When it comes to the major extracellular ions, we're talking both the plasma and the interstitial fluid. Remember, the only difference between those two fluids is the presence of proteins in the vascular fluid. So they should be very similar, and what you're going to find is that sodium, chloride, and bicarbonate are the major extracellular ions. Okay, we're going to review some of the controlling fluid and electrolyte movement mechanisms. So here they are, just in a very quick format. So as we go through the next few slides, this is what we're talking about. It's a little bit subtle, but over here on the right side, you should be able to see that there are more dots than there are on the left side. So that means there's a higher concentration on that right side. And so there's going to be a tendency for the dots to diffuse across, so that after diffusion you'll see the number of dots are equal on both sides. Now on this next slide, what we have is we have a membrane that is permeable to water, but it's not permeable to the dots. So what we find here is we have more dots, so there's a higher concentration, and now because the dots can't move across, what we're finding is that the water moves the other direction instead. So osmosis is when water diffuses to an area of higher concentration. So remember, diffusion always goes from high concentration to low concentration, and water will go from high concentration of water, or low concentration of solute, to a high concentration of water, to a lower concentration of water, meaning a higher concentration of solute. So water moves backwards if you're thinking about osmolarity, or the amount of electrolyte. Just a reminder that the cell membrane is semipermeable. It allows water to move freely across both directions. However, it's going to pump sodium out and potassium in. So this is just an illustration of what happens to a cell membrane when you put it in different types of solutions. So let's start with the middle one, isotonic. So if the amount of dots, electrolytes, are the same as inside the cell, the concentrations are equal, then the amount of water moving in and out of the cell is going to be the same, and the cell will stay the same size. Over here we have an hypotonic solution. There's not as many dots outside the cell as there are inside the cell. What that means is that water from outside the cell, where there's a higher concentration of water, is going to want to move inside the cell, and that's going to make the cell grow larger. If the cell grows too large, it will actually break open, and we call that lysis. Over here on the right-hand side, what we have is we have a solution with lots of dots, more dots than there are on the inside. So now the fluid on the inside of the cell has a higher concentration of water than outside the cell. And so water is going to want to move out net, and that's going to shrink the cell. That's actually one of the mechanisms behind why when you gargle with salt water, it actually makes your throat feel better, because it's hypertonic solution and it's actually pulling fluid from those inflamed cells in the back of your throat, thereby shrinking them and making you feel better. Let's take a quick look at osmolarity. Now you'll notice that sodium, normal values are about 135 to 145, calcium is about 8.5 to 10.5, and potassium is about 3.5 to 5. Now, these numbers are not necessarily the exact numbers you need to memorize. They're just to give you an idea of the sizes that we're looking at, or the proportions. And you'll notice that sodium is just far more than any of the others. So when it comes to the osmolality equation, you're going to take 2 times the sodium level, and that's more or less what normal tonicity is. There's a little bit you're going to add on later, BUN and glucose. However, the vast majority of osmolality does come from sodium. This is just a review of the inflammatory edema, that you can have proteins exerting oncotic pressure. So basically they are also causing, not like an electrolyte, but kind of like an electrolyte, it's going to increase the concentration of stuff that's dissolved in water, thereby exerting a pull on fluid. Okay, we're just going to briefly talk about the movement of fluid between the extracellular fluid and the intracellular fluid. So you can actually have an excess or a deficit in intracellular fluid depending on the direction of movement. So, for example, you can have a water deficit in the intracellular fluid by if fluid is moving from the cells into the extracellular fluid. So that's going to be if there's hypertonic solutions in place, or if there's an increase in osmotic pressure that's going to pull fluid out of the cells into the extracellular fluid. On the other hand, if you can have a water excess, if you have decreased extracellular fluid. So the fluid is coming from the extracellular fluid into the cells, and in that case the cells are going to swell. Just some slang. We have what we call first spacing, second spacing, and third spacing. First space is when you have a normal distribution of fluid in the intracellular and extracellular compartments. Second spacing is when you have an abnormal accumulation of interstitial fluid, also known as edema. And then third spacing is when you have fluid accumulating in parts of the body where it's not supposed to be in the first place. So body cavities. An example of that would be ascites in liver failure, where you have an accumulation of water in the ventral cavity. Over the next couple slides, we're going to talk about the regulation of water balance very, very quickly. All right, this fun slide illustrates how fluid and electrolyte balance operates. So let's just start up here at the top with stress. stress signals to the hypothalamus. Hypothalamus is going to ask the pituitary to secrete adrenocorticotropic hormone. Adrenocorticotropic hormone is going to stimulate the production of aldosterone and cortisol. Now, aldosterone is going to cause the kidney to absorb more sodium, thereby absorbing more water. So it's going to cause fluid and sodium retention. At the same time, when you have the hypothalamus being stimulated, it's going to stimulate the posterior pituitary to secrete ADH. ADH, in return, is going to tell your body to hold on to water, but allow sodium to be excreted. On top of that, you also have the renin-angiotensin-aldosterone cascade, and that is going to be released when either the kidneys feel hypoxia, they're going to start releasing renin, as well as under the influence of beta receptors in the kidney when there is sympathetic response. So renin facilitates angiotensin 1 production, and then angiotensin 1 is turned into angiotensin 2 by angiotensin converting enzyme, and then angiotensin 2, among other things, is going to cause aldosterone secretion, which we already talked about. Aldosterone causes the reabsorption of sodium and thereby water. And then we have one more thing that comes to the party to help things out, and that is the heart itself and the endothelium. So the heart produces two peptides called atria natriuretic peptide and ventricular natriuretic peptide, which we call BNP, and then endothelium produces a third natriuretic peptide called CNP. Now, all three of these natriuretic peptides tell the kidneys to get rid of water. So the heart's basically saying, I've got too much water, I don't need any more, please get rid of it. Now, sometimes what you'll have is you'll have all of these different things going at the same time. So the kidneys are being told, hold on to fluid and sodium. And then at the same time, they're also being told by the heart, through ANP, BNP, hey, we've got too much water, you need to get rid of it. Usually, the kidneys err on the side of keeping the water when it's got these conflicting signals at the same time. Okay, let's talk about some fluid status indicators. So, on a physical exam, are the mucous membranes moist or are they dry? So, ask the patient to open the mouth and look at it. Turgor is the skin, does it have good turgor or does it have tenting? Remember that tenting, you want to test for tenting either on the sternum or on the forearm. Don't do it on the back of the hand. Take a look at the blood. If there's dehydration, if there's lower blood volume, chances are that the hematocrit will be higher. The amount of blood cells will be higher per volume of blood. On the other hand, if there's fluid excess, then the hematocrit is going to be lower because more of the blood is going to be fluid. Within the plasma, you can look at the BUN level, which reacts very similarly to hematocrit. And when there's fluid overload, BUN is low. When there's fluid deficit, BUN is high. You can also look at the urine. You can look at the output of urine. Is there a large output or a small output? And you can also look at the specific gravity. Is it more concentrated or less concentrated? The higher the specific gravity, the more stuff is in there. The lower the specific gravity, the less stuff is in there. And then finally, you can also look at electrolytes, particularly sodium. And then also BUN. And then you can also look at creatinine to give you an idea of kidney function. Now, one thing that is not on this slide is actually the most important thing. The most important thing is anytime a patient has low blood volume, what they're going to do is they're going to get a sympathetic response. The sympathetic response is going to cause high heart rate that's going to help compensate for the low blood pressure. So when you have a patient with low blood volume, they are typically going to have high heart rate low blood pressure. If you see that particular pattern, it's extremely dangerous. It's a sign that the patient has dehydration. On top of that, because the patient is squeezing for all they're worth already, because of vasoconstriction from the sympathetic response, they're going to have more orthostatic hypotension. So, the patient already has some vasoconstriction. So when they stand up, they don't have as much vasoconstriction to go. They've already kind of used it all up, and so that's going to cause orthostatic hypotension as gravity pulls that fluid down into the patient's legs. So two important signs of fluid deficit. First one, the pattern of increased heart rate, low blood pressure, and the second one, orthostatic hypotension. Now, when it comes to fluid and electrolyte balance, you can have fluids be normal or contracted or expanded. At the same time, the electrolytes can be isotonic, hypertonic, and hypotonic. So you've got three possibilities for fluids and then three possibilities for electrolytes. And so you can have any combination between the top and the bottom. Now this slide is really just showing you the relationship of fluid contraction and expansion in relation to sodium. So over here on this side we have extracellular contraction. So basically you don't have enough fluid. And then we're saying if that fluid volume deficit is occurring because of a water deficit, then as you lose water but you keep the same amount of sodium, eventually you're going to have hypernatremia. So if you lose fluid but keep the same amount of sodium, eventually they're going to have a higher concentration of sodium, thereby hypernatremia. Now, if the reason you have the fluid volume deficit is because you have sodium deficiency, so remember, water follows sodium. So as sodium leaves the body, so does fluids. Then you're going to end up with hyponatremia. And then you could have an isotonic fluid deficit where you're losing fluid and sodium at the same rate. In that case, you're going to have a normal sodium level. On the other side, on the extracellular expansion side, now we've got too much water. So if we have a pure water excess, what we're going to do is we're going to dilute the amount of normal sodium that we have, and we're going to end up with hyponatremia. If what we have is we have a sodium excess, remember, water tends to follow sodium. So as you hold on to sodium, you're going to hold on to more water also. You're going to end up with a hypernatremia. And then if you're gaining water and fluid at the same rate, you're going to end up with normal sodium. So we're just going to take a look at causes of extracellular fluid deficit. Now, the reason why we don't call it dehydration is because dehydration is really when you lose fluid but not sodium. In this case, we're not talking about the osmolality or osmolarity, we're just talking about fluid volume decrease. So, some common causes. You don't drink enough. You pee too much. You sweat too much. You have a burn. As you get a burn, you destroy tissue, and fluid is going to leak out into that destroyed tissue. Diarrhea, fairly self-explanatory. Vomiting, also self-explanatory. And bleeding, also self-explanatory. Now, the major treatment for extracellular fluid deficit is number one, stop the underlying disorder. If the patient is bleeding, it doesn't really matter how much fluid you pump into them if they're bleeding faster than the amount of fluid you're putting in. If they continue to have diarrhea, you can keep putting fluid in, but eventually you've got to stop that diarrhea. So number one thing, stop the underlying disorder. Number two, replace fluids appropriately. And then number three, treat any complications that occur. Now this little beautiful slide here shows you classifications of different kinds of fluids. So remember we said treat appropriately. What we mean is with the appropriate fluid. So the first question is it going to be PO or is it going to be IV? The rule of thumb for the test is if the patient's systolic blood pressure is lower than 100, we're going to give them IV fluids. If it's above 100, you can give PO fluids. We're going to talk about this lovely little diagram later on when we talk about fluids in more detail. Okay, so if the patient has an isotonic deficit, you can give them PO electrolyte drinks like Exceed or Gatorade, or you could give isotonic saline, IV, so like normal saline. If it's a hypertonic deficit, so they have too much sodium now, but they also have a fluid deficit, you can have them drink pure water, or you can give them a hypotonic solution such as half normal saline or D5W. If the patient has a hypotonic deficit, so now they don't have enough sodium, you're typically going to give isotonic saline or normal saline. Theoretically, you could give hypertonic saline, however, it's extremely dangerous. So really the only time you're going to see hypertonic saline used is in the case of cerebral edema. So when you give hypertonic saline, it actually pulls fluid out of the tissues into the blood. And in the case of cerebral edema, it pulls it from the brain into the blood, thereby shrinking the cerebral edema, thereby reducing the amount of damage done during cerebral edema. Okay, as far as extracellular fluid excess goes, there's three main causes, and those are the three failures: heart failure, liver failure, and kidney failure. In addition to those, you could also have excess intake, or you could have, well, yeah, pretty much excess intake. If you have decreased excretion, that's really a kidney problem. So let's just very briefly explain why those things happen. First one is the heart. In the heart failure, the body isn't getting enough blood being pumped to it. So the body interprets that as, hey, maybe you need some help. Maybe heart, maybe you need a little extra blood to pump. So it starts to hold on to fluid and sodium. Unfortunately, it doesn't make the problem better, it actually makes it worse. In the case of liver failure, the liver produces albumin. But in liver failure, it's not producing enough albumin. That's going to decrease osmotic pressure, and you're going to have edema and also accumulation of fluid in the abdomen called ascites. So the patient is overloaded. However, most of that fluid is not in the blood vessels, it's in the tissues, it's in edema and ascites. So they actually are going to have signs and symptoms of low blood fluid when it comes to the heart and the cardiovascular system. So they're going to have low blood pressure, high heart rate. In the case of kidneys, what you're going to have is you're going to have the kidneys just not getting rid of fluid, so they're going to accumulate fluid. As far as the treatment goes, you're going to try and remove fluid. In the case of heart failure and kidney failure, with the heart, you're going to give diuretics. With kidney failure, you can use diuretics until it gets bad enough to where they don't work anymore, and then in that case, you're going to use dialysis. In the case of liver, it's much more complicated, and we'll talk about that in Patho Pharm too. Don't memorize these exact values because the values that you're going to memorize are the ones on your lab sheet. Okay, now what we're going to do is we're going to look at some of the more common electrolytes and the signs and symptoms that are most common when they're high or low. So if you have too much sodium, call it hypernatremia, and it's associated with being thirsty, and then CNS deterioration, so basically your brain function doesn't function as well, and then increased interstitial fluid. When we say CNS deterioration, at the extremes you can actually have seizure, coma, and death. As far as deficit goes, same thing, just CNS deterioration. All right, now when potassium is high, hyperkalemia, it's going to affect ventricular fibrillation. It's going to cause ventricular fibrillation and eventually actually stop the heart altogether. That is the way that we stop the heart during heart surgery. You basically put a fluid, an ice solution of high potassium fluid on top of the heart, and that makes it stop. When it says ECG changes, you could also say dysrhythmias. How do you know a patient has a dysrhythmia? You do an electrocardiogram, ECG. CNS changes, central nervous system changes, same thing here, and then weakness. Now, on the deficit side, you don't have enough potassium, hypokalemia. You're going to have bradycardia. So, if you think about it for a second, ventricular fibrillation, the heart is going so fast that it eventually just starts kind of vibrating or quivering. On the other hand, if potassium is low, the heart starts going slower and slower and slower, bradycardia. ECG changes again, dysrhythmias. So too much potassium, dysrhythmia. Too little potassium, dysrhythmia. Number one most important thing about potassium being off, dysrhythmia. All right, if you have too much potassium, or sorry, too much calcium, call it hypercalcemia. Gets you thirsty, central nervous system deterioration, and then also can actually cause increased interstitial fluid, can cause edema. When you don't have enough, it ends up causing tetany. Now, tetany is not the same as tetanus. Tetanus is a disease caused by a bacteria. Tetany is just muscle spasm. It is a symptom of tetanus. So on the test, if you put down tetanus, you will not get credit because it's not tetanus. There's no infection here. Capiche? Some other signs, muscle twitching, central nervous system changes, and ECG changes. Now, low calcium is especially dangerous in the presence of high potassium. So, low calcium, high potassium, bad juju. Alright, fine, I'll tell you what Chvostek's and Trousseau's sign are again. Chvostek's sign is when you tap on the patient's cheek and it causes a snarl. Arr. Trousseau's sign is when you pump up a blood pressure cuff on the patient and it makes their wrist flex. All right, let's take a look at magnesium. If there is too much magnesium, then you're going to end up with a loss of deep tendon reflexes. It also causes depression of the central nervous system and depression of neuromuscular function, i.e. muscle flexidity. On the other hand, if you have low magnesium, you're going to end up with hyperactive deep tendon reflexes and muscle spasm. One thing to note about magnesium is that most of the magnesium in your body is inside of cells, so sometimes you can have a normal magnesium level in the blood, but still have a deficit in the cells. So you can still have a patient who has signs and symptoms of low magnesium even though they have normal magnesium levels. Pretty cool, huh? Okay, as far as hypernatremia goes, there's nothing really new on there. Impaired LOC means impaired level of consciousness, so the patient will lose consciousness. The main cause of hypernatremia is going to be diabetes insipidus, where typically there is too much not enough ADH, which allows large amounts of water to be lost, but sodium stays inside the body. The main thing here is that you want to reduce sodium levels slowly, because if you don't, it can cause cerebral edema. The main way that you're going to lower it is by giving the patient low sodium fluids. And if necessary, you can give diuretics, because diuretics will cause sodium to be excreted in the kidney. You can get hyponatremia from one of two different ways. The first one is if you lose too much sodium. The second way is you can gain excess water. So, when it comes to hyponatremia, you can lose it through sweat, diarrhea, vomiting, you name it. Or, if you get it from too much water, drinking too much water is one of the main ones, and then drowning in fresh water is another potential one. Manifestations of hyponatremia, we already talked about what they are. Treatment: give sodium chloride. Ta-da! You can give it orally if it's not too bad, and if the patient is conscious. If the reason they have it is because they have water excess, they need a fluid restriction. There's a lot of elderly folks who have incompetent kidneys who can't drink more than a liter a day of any fluid. So a liter is not that much fluid. Um, think about if you could only have 1 liter of anything, all to put together: orange juice, coffee, water, Coke, you name it, no more than 1 liter a day. Yeah, you'd probably be pretty, what's the word? Crabby. If the hyponatremia is severe, you can give a very small amount of hypertonic saline, but again, that's very rare. You're hardly ever going to see that because the hypertonic saline is so dangerous. If the patient has abnormal fluid loss, and that's the reason why they're getting this, then what you want to do is you want to replace the fluid at the same time as you replace the sodium. Typically, it's going to be normal saline. High potassium is extremely dangerous, partly because the normal value of potassium is so very small. So, high potassium can be caused by large intake, impaired renal excretion, that's typically going to be during renal insufficiency or renal failure, or a shift from the intracellular fluid to the extracellular fluid, such as during acidosis, or when cells break open. Remember, the reason that the potassium in the blood is so small is because most of the potassium in the body is inside of cells. So if cells are destroyed suddenly, such as a burn, crush injury, or tumor lysis, you can have large amounts of potassium being leaked out into the extracellular fluid. And then finally, some drugs can cause potassium to increase. We're going to learn about those drugs in Pathopharm too. One thing to note is that you can have a false high if the blood sample hemolyzes. So remember, most of the potassium is inside of cells, including red blood cells. If the red blood cells in your sample break open, that's going to cause a false high. Manifestations going to cause weakness or paralyzed skeletal muscles, ventricular fibrillation or cardiac standstill, or in less severe cases, just a dysrhythmia. And then it can also cause abdominal cramping and or diarrhea. The number one most important thing you need to remember is dysrhythmias. This slide right here just shows the changes that can happen in an electrocardiogram. So here is the normal one. And then what you see here with low potassium, shallow T wave and a large U wave. And then in hyperkalemia, what you see is you've got a widened QRS, and then you have this kind of depressed ST segment and a large, tall, peaked T wave. You are not expected to recognize these particular things, but they are for illustration. When it comes to treatment, we use a stepped treatment. So if the potassium is very high, then the very first thing we want to do is we want to give calcium gluconate. Calcium gluconate IV does nothing for the actual potassium. However, it does protect the heart from that high potassium. Also, if the patient is receiving potassium, especially if they're receiving it IV, you want to stop that potassium intake immediately. The next thing we can do is we can try and force potassium from the extracellular fluid to the intracellular fluid. That's going to take somewhere between an hour to 3 hours to occur. And the two ways we can do that is we can give IV insulin, or we can give sodium bicarbonate. Now, when we give IV insulin, we're also running the risk of hypoglycemia. So in addition to the insulin, we're also going to give a little bit of glucose at the same time. And then the long-term solution is to increase the elimination of potassium. So diuretics can do it, although that's not really what they're used for. If the reason they're having high potassium is because of kidney failure, you can use dialysis. And for general use, what you're going to use is a substance called K-exolate. So K-exolate is a gel that you ingest, and then it absorbs potassium into the gut, traps it, so you poop it out. That being the technical term. Low potassium. Now, when it comes to low potassium, you can have it because you lose too much via the kidneys. That's typically going to be because of diuretics, Or you can lose too much of it from the intestinal tract, and that's typically going to be either diarrhea or vomiting. It can also be caused by magnesium deficiency and metabolic alkalosis. So, just like acidosis causes too much potassium, alkalosis causes not enough potassium in the blood. The manifestations are pretty much just the opposite of hyperkalemia. As far as skeletal, you're still going to have skeletal muscle weakness, but you're also going to have decreased gastrointestinal motility. So in the case of hyperkalemia, you had diarrhea and hypermotility. Now in the case of hypokalemia, you're going to have lower motility. However, the most important manifestations are always cardiac, so dysrhythmias. Potassium chloride is the usual supplement, and it can be given either orally or IV. Oral supplements are usually long-acting because otherwise you'd have to take it like every hour, every other hour. You should not exceed 10 to 20 milliequivalents per hour, and really 10 is when it's IV. If it's IV, never more than 10. To prevent hyperkalemia and cardiac arrest, that's the reason why you're doing it. Yeah, your potassium was low, so we gave you some potassium. We gave you a little too fast, and next thing you know, you just died on us. Oops. One other rule is no P, no K. If the patient is not producing urine, they should not ever get potassium. And the reason for that is if they're not producing potassium, and you give potassium, then they have no way of getting rid of that excess potassium, and so they're going to very, very quickly become hyperkalemic. It sounds really silly, but I can tell you that I've had multiple students come back over the years and say, "You saved a life today, Dr. Heyman. No P, no K." So maybe it'll save a life for you too one day. Yeah, your bones are made of calcium. Your teeth too. Calcium phosphate to be exact. So, calcium and phosphate are always inverse relationship in the blood. Otherwise, you're going to get calcium phosphate formation in the blood, and that just wouldn't be kosher. Read what it says. Just want to mention that in the blood, some of the calcium is bound to albumin. So, only the part that's free or ionized is available to do whatever it is supposed to do. So what that means is if the patient has low or high albumin, that's going to affect the effective amount of calcium. So if a patient has low albumin, they're going to have effectively higher amount of available calcium. And so they could have signs and symptoms of hypercalcemia even if they have normal calcium levels in a patient who has low albumin. Calcium does a huge number of things in the body, but you only need small amounts of it in all those different little parts of the body. Where you need a lot of it is in the formation of teeth and bones. And the calcium balance is controlled by parathyroid hormone and calcitonin. They have opposite effects, and they primarily affect the blood level. So the goal of calcitonin is to lower the blood level of calcium. The goal of parathyroid hormone is to increase the blood level of calcium. So there's three reservoirs that they take or put the calcium. So the first one is bone itself. So calcitonin says take this excess calcium in the blood and put it in the bone, whereas parathyroid will do the opposite. It'll say take it from the bone and put it into the blood. It can also go into the kidneys, so calcitonin will tell the kidneys excrete more calcium. Parathyroid hormone will say reabsorb that calcium back into the blood from the urine. And then the third place is the intestine. Calcitonin will decrease the absorption of calcium, whereas parathyroid hormone will increase the absorption of calcium. Now, when it comes to the absorption of calcium, you actually have to take some, but you also need vitamin D in order to absorb it. Um, it's also better absorbed in the presence of magnesium. Hypercalcemia is much less common than hypocalcemia. You can see the most common causes here. Manifestations: decreased memory, confusion, disorientation, fatigue, and constipation. You didn't really need me to read that, did you? Okay, when it comes to treating high calcium, you can cause the excretion of calcium with loop diuretics. However, that's also going to make you lose water and sodium and chloride and potassium. So, not necessarily the best scenario. You can also hydrate the patient with normal saline and dilute the amount of calcium. You can also use synthetic calcitonin, and then you can also use calcium chelators, such as citrate. So you'd infuse citrate or another calcium chelator. It would bind to the calcium so that it's no longer biologically active. Hypocalcemia or low calcium is much more common than hypercalcemia. Some common causes include decreased production of parathyroid hormone, acute pancreatitis, multiple blood transfusions, and the reason for that is that packed red blood cells are preserved with citrate. Citrate, remember we said that blood clotting uses calcium. So when you give citrate, when you put the citrate into the packed red blood cells, it binds to the calcium, and so that will prevent blood clotting while it's in the bag. So when you give it to the patient, it's got citrate in it, which can bind to the patient's calcium, which in turn can lower the patient's calcium levels. Alkalosis can cause hypocalcemia, and then decreased calcium can also cause hypocalcemia. When it comes to manifestations, patients are typically going to have muscle spasm. Now, weakness, um, it doesn't mean that the muscles don't contract, but that the contraction isn't necessarily helpful. So, weakness or tetany. Tetany, remember, is muscle spasm. It is not to be confused with tetanus. Positive Trousseau or Chvostek sign, you can see A and C there are showing you what those are. And then laryngeal stridor, so the patient could sound like that. Dysphagia, patient has trouble swallowing, and then tingling around the mouth or the extremities. Underlying treatment, if you know what the cause is, treat the underlying cause. And then you need to give calcium supplements, typically going to be oral or IV. Um, when it comes to IV supplements, calcium gluconate is the most common. We already talked about that as a treatment for high potassium, and you can also use it to treat low calcium. Um, when it comes to oral, an important thing to note is that they're not all created equal. So calcium carbonate has higher levels of calcium in it. However, it's not quite as well absorbed as calcium citrate. The only thing I'm going to say about phosphate is that it's going to always go opposite in the blood of calcium. So if calcium's high, phosphate will go low, and vice versa. Magnesium also has very low levels and very narrow levels, similar to potassium. However, it's not as dangerous as potassium is. An interesting thing about magnesium is that most of it is not in the plasma, most of it is actually inside of cells. So you can have normal plasma levels and still have low magnesium because you don't have enough inside the cells. That's going to become very, very important when it comes to cardiac patients. Um, Magnesium acts as a coenzyme for a lot of things, and one of the things magnesium helps do is regulate the heart cycle. So if you have a patient with low magnesium, they tend to have dysrhythmias, and so and cause weakness of the heart. So you've got to make sure the patient has enough calcium. So even though, or sorry, enough magnesium. So even though the normal magnesium level is 1.8, for a heart patient, you're going to err on the side of caution and you're going to want them to be above 2. So for usual patients, 1.8 is okay. But for heart patients, it needs to be at least 2. Now, when it comes to high magnesium, the major cause of high magnesium is if you take too much magnesium and you have renal insufficiency or renal failure. Um, Ordinarily, taking magnesium supplements doesn't cause anything other than some diarrhea. The diarrhea pulls magnesium out of your blood, and it's a self-limiting problem. But when you have renal insufficiency or renal failure, now all of a sudden you can get some really high magnesium levels. The other reason for high magnesium levels would be IV magnesium, where it's given too fast. Manifestations of high magnesium include lethargy or drowsiness, nausea and vomiting, and impaired reflexes. And the reason why there are star is because that is what you are going to assess. And then respiratory and cardiac arrest. The key to hypermagnesemia is number one, try and prevent it if you can. And that goes back to those assessments. If you are giving a patient magnesium, whether it's oral or IV, you want to take some precautions. If you're giving oral, the number one precaution is to check renal function. And that includes if you're giving magnesium as a laxative. Milk of magnesia, or magnesium hydroxide, is a very commonly used laxative in the hospital and in outpatient. So if a patient has renal insufficiency and you give them that milk of magnesia, that can cause hypermagnesemia. So the very first thing is for oral magnesium, check kidney function. For IV magnesium, what you're going to do is you're going to assess deep tendon reflexes before you start to give it and then while you give it. For emergency treatment of hypermagnesemia, you're going to give IV calcium chloride or calcium gluconate. So, giving higher doses of calcium helps to protect the heart from the excess magnesium, similar to the way that it does with high potassium. All right, when it comes to low magnesium, you can get low magnesium from prolonged fasting, alcoholism, fluid loss from the GI tract, that's going to again be vomiting or diarrhea, and then prolonged parenteral nutrition. So remember TPN, total parenteral nutrition, without magnesium supplementation. And then finally, diuretics can help you get rid of magnesium quicker than you want to. Manifestations include confusion, hyperactive deep tendon reflexes. So you lose the deep tendon reflexes when you have too much magnesium. When you don't have enough, they become hyperactive. Tremors, seizures, and cardiac dysrhythmias. So when you have too much magnesium, you lose muscle tone, and then when you have not enough, you get tremors because of too much muscle tone. When it comes to treating hypomagnesemia, you're going to either give oral or IV supplement. So when it comes to oral supplements, you can give magnesium oxide, magnesium hydroxide, also known as milk of magnesia, or magnesium sulfate. As we said earlier, all of these magnesium preparations have a mild laxative effect, depending on the dose, maybe not so mild, and so they are going to be somewhat self-limiting in terms of the ability to cause hypermagnesemia. The one exception to that rule when you're giving PO is if the patient has renal insufficiency. When it comes to giving IV magnesium, on the other hand, it is very easy to give the patient too much magnesium. So before you give magnesium IV, you have to take deep tendon reflexes, and then while and after you're giving it, you also want to reassess those deep tendon reflexes. And the most common form of magnesium IV is magnesium sulfate. Okay, what we're going to do now is we're going to talk a little bit about acid-base balance. So there are two buffer systems in your body. Those are carbonic acid and bicarbonate. Carbonic acid is formed when carbon dioxide dissolves in water, and bicarbonate pushes that reaction back towards carbon dioxide. So the more carbon dioxide you have in the system, the more acid you're going to have. The more bicarbonate in the system you have, the more base you're going to have, or alkaline. Now, there's two major organs that are in charge of carbon dioxide and bicarbonate. What's in charge of bicarbonate is the kidneys, so we call that metabolic. What's in charge of carbon dioxide is the lungs, so we call carbon dioxide respiratory. So let's think about this for a moment. Bicarbonate is a base, so if bicarbonate is high, that's going to give us metabolic alkalosis. If bicarbonate is low, that's going to give us metabolic acidosis. Now, it's important to understand that acidosis and alkalosis does not mean the net pH of the blood. It just means a process tending toward acid or tending toward alkalosis. When it comes to respiratory, if carbon dioxide is high, carbon dioxide is an acid, so high acid, acidosis, respiratory acidosis. If, on the other hand, carbon dioxide is low, then it's going to be respiratory alkalosis. One important thing to note is that when you see CO2 on a basic metabolic panel, that is not really carbon dioxide at all, it is actually bicarbonate. In order for it to be considered actual carbon dioxide, it needs to be taken from arterial blood, and you're going to see a P in front of it for pressure of carbon dioxide. And if it's not enough, here it is again. CO2 on a BMP means bicarb. Don't confuse it. Now, anytime you have acidosis, there is the potential for hyperkalemia, so it's extremely important to check for potassium levels when you have a patient who's in acidosis. Metabolic acidosis can cause drowsiness, confusion, headache, and coma. And that's the neuro effects. Cardiovascular can be low blood pressure, dysrhythmia via the high potassium, and then dilation of arteries. In the GI tract, it can cause nausea, vomiting, diarrhea, abdominal pain, and in the respiratory tract, it can cause increased respirations as a compensatory mechanism. Metabolic alkalosis. So remember, anytime the patient has alkalosis, that can cause hypokalemia. So again, you need to check potassium levels. So within the nervous system, we have dizziness, irritability, nervousness, and confusion. In the cardiovascular system, high heart rate and dysrhythmias because of low potassium. GI tract, we have nausea, vomiting, and anorexia. And in the neuromuscular, we have tetany, tremor, paresthesia, and seizures. And then in respiratory, you can have a decreased respiratory rate as compensation. Okay, so now we have interpretation of ABGs in 6 steps. I've actually compressed it down to 4 steps. So if you're already listening to this after you had class, then I consider evaluate the pH, PaCO2, and bicarb all as 1 step now. So basically, label them. And then the next step, instead of determine if balanced or unbalanced, and then determine if CO2 matches the alteration, what we're going to say is match your emia to your osis, or match your osis to your emia. And then the last step is to look back at the other osis to see if you have the opposite. And then the final step is to check the pH to see if it's partial or complete compensation. So let's just do this one real quickly here. So here we have the pH is 7.36. That is within the normal range, but it's toward acidemia. So we can say that it's acidemia-ish. The PaCO2 is 67, which is high. High acid means that we have respiratory acidosis. PaO2, 47, that's low. So that means that we have hypoxemia. And then bicarbonate is 37. That's high. So we have metabolic alkalosis. So what we have is we have respiratory acidosis, metabolic alkalosis, and then here we have acidemia-ish. So we match our osis to our emia, and so what that means is acidemia-ish matches respiratory acidosis. So our primary is going to be respiratory acidosis, and then we're going to look at the other osis, and so metabolic alkalosis is the opposite of acidosis, so therefore we have compensation. Now our last step is to look back at the pH and decide, is it within normal limits? If it is, then it's complete or full compensation, and if it's outside of normal range, then it's partial compensation. So in this case, it is within the normal range, and we have complete compensation. So if you want to rewrite it as an English sentence, you could say, fully compensated respiratory acidosis. All right, when it comes to putting everything together in terms of electrolytes and fluid acid-base balance, always pay attention to the patient history. Have they been vomiting? Have they been having diarrhea? Have they had a burn? You know, what's going on with them? What are their vital signs? Remember, extremely, extremely important, that pattern of high heart rate, low blood pressure, classic sign of hypovolemia. Do they have pallor, which would be a sign of vasoconstriction from sympathetic response? Look for symptoms and physical exam findings. Do they have dry mouth? Do they have sunken skin under their eyes? Do they have poor skin turgor? Do they have normal urine output? All of those things matter. And then finally, look at lab values. Sodium level in particular, creatinine level, BUN, those are probably the 3 most important ones. And then you can also look at bicarb in terms of acid-base balance. Now, when I said most important for fluid status. And then in terms of most important in terms of potentially killing the patient quickly, potassium is the most important. Always ask yourself, what's causing this abnormal finding? Look back at the patient history. Is there anything that you can see in the patient history that might be causing it? And then the next question is, what can be done to fix the problem? If you know what's causing it, it should help you to know how to fix it. Okay, let's talk about the fluids in a little bit more detail. So we separate fluids out into two main categories, crystalloids and colloids. Crystalloids are crystal clear, whereas colloids are cloudy. The reason colloids are cloudy is because they're not truly solutions, they are suspensions. So just like orange juice is a suspension. If you don't shake it up, then the stuff settles to the bottom. So there's things floating around in there, and that's what makes it a colloid. Colloids have something in common, is that they increase plasma osmotic pressure, so they are going to help pull fluid into the patient's bloodstream, into the vascular space from the tissues. Crystalloids are crystal clear, they're completely dissolved, and we're going to talk about these in the next couple slides. Fluids, the crystalloids do come in three flavors: hypotonic, isotonic, and hypertonic. And so you typically want to match the fluid to the patient's state. If they're isotonic, you typically want to give an isotonic fluid. If the patient is hypertonic, you'd want to give it a hypotonic fluid, and if you get the idea. Okay, two main purposes for giving IV fluids. The first one is for maintenance. So that's the patient doesn't have a fluid deficit now, but their oral intake might not be adequate. Maybe they're going to surgery, or maybe the patient is NPO. So you might give IV fluids to help maintain the patient's normal blood pressure and fluid status while they're not drinking. The second purpose is replacement, and that occurs when a loss of fluid has occurred. D5W is dextrose 5% in water. Now remember that glucose comes in two forms, D-glucose and L-glucose. D-glucose is dextrorotatory, so dextrose for short. It provides a small amount of calories in a liter, and it's basically free water. What that means is that there's so little solute in it, there's so little glucose, that basically as soon as the water gets in, as soon as the D5W goes into the patient's vein, the glucose is absorbed and just, never happened. Now you just have some extra water floating around. That extra water is going to leave the vascular system, and is going to go into tissues. And it's typically used to replace water losses, and then also to treat hypernatremia. It says treat hyponatremia. Sorry, treat hyponatremia, because what's going to happen is it's going to cause fluid to move out of the tissues. Or sorry, out of the blood into the tissues. Okay, we're missing half normal saline, or 0.45% saline. So the important thing to note is that pretty much everything that we say about normal saline, half normal saline is the hypotonic version and provides less sodium. Now, normal saline is isotonic. There's no calories in it, and it provides more sodium chloride than is typically in the ECF. So it's ever so slightly higher than the normal sodium value. 30% of normal saline will stay in the intravascular fluid, and 70% of it will move into the tissues. Normal saline will expand the intravascular volume, and so it's the preferred fluid for immediate response. If a patient is hypovolemic, if the patient has had an emergency, if they've had a gunshot wound, if they're bleeding to death, whatever it is, if the patient is hypovolemic, normal saline is the preferred solution. Now, the risk for fluid overload is higher with normal saline than with some of the other fluids, because 30% of it stays in the blood. It's also the only it's the only fluid that we give in combination with blood products, and it's also the most universally compatible fluid with medications. There are only very few medications that are incompatible with normal saline. Lactated ringers is another isotonic solution. It is more similar to plasma than normal saline. It has a little bit less sodium chloride, and it also has potassium, calcium, phosphate, and lactate. Lactate is turned into bicarbonate by your liver, which means that it's contraindicated in severe liver damage and in patients who are at risk for lactic acidosis, because in that case, the lactate will just build up and make the problem worse. Lactated ringers does expand the extracellular fluid, so it can be used for patients who are hypovolemic, but normal saline is typically the drug of choice for that. This is more for maintenance fluids. And there are a lot of drugs that are not compatible with lactated ringers. Okay, D5W in half normal saline is a hypertonic solution where you have combined the same amount of glucose and the same amount of sodium chloride that you would get in each of the hypotonic solutions. You put them together in the same amount of water and you get hypertonic. It's a very common maintenance fluid because it does not cause increased sodium, but it helps to maintain plasma volume. And sometimes you'll see potassium chloride added to it for maintenance or replacement of potassium. Okay, D10W is also hypertonic. It is the maximum concentration of dextrose that can be administered in a peripheral IV. If you want to go a higher concentration, instead of higher concentration than D10W, you'll have to go to a central IV line. Central lines are typically going to be subclavian, interjugular. There are others as well, but those are the most common ones. Okay, plasma expanders are going to cause an increase in plasma osmotic pressure, and they're going to draw fluid from the intracellular space into the from the intracellular space into the vascular space. So they have 4 different kinds. Packed red blood cells, those are special. We'll talk about those in a second. Albumin, which is basically just an albumin solution. Plasma, or fresh frozen plasma, which is basically just exactly what it sounds like. It has proteins in it as well as electrolytes. And then dextran. Dextran is a starch that is going to act like albumin and increase plasma osmotic pressure. Now, packed red blood cells, we said, are a little bit special, and the reason they're special is because they can carry oxygen. So, you don't give whole blood to patients because the risk of fluid overload is just too great. So by reducing the amount of plasma available in the red blood cells, we get what's called packed red blood cells. Packed red blood cells do increase the plasma osmotic pressure, but they also increase the oxygen carrying capability of the patient's blood. There's an important consideration anytime you give packed red blood cells, which is that you have to match the blood so that you don't have transfusion reactions, where the patient's body rejects the blood that's being given. And then finally, packed red blood cells are preserved with citrate, so you have to check the patient's calcium level, especially if they're receiving more than 1 unit, because the citrate in the packed red blood cells will bind to the patient's own calcium.